Hello friends, Indian Chess Society, in association with its educational partner, Glenmark, has finished 15 webinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this webinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API Epics webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India, with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these webinars. Hello friends, Indian Chess Society, in association with its educational partner, Glenmark, has finished 15 webinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this webinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API Epics webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India, with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these webinars. Hello friends, Indian Chess Society, in association with its educational partner, Glenmark, has finished 15 webinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this webinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API Epics webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India, with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these webinars. Hello friends, Indian Chess Society, in association with its educational partner, Glenmark, has finished 15 webinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this webinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API EPICS webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India, with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these webinars.
Good evening, everyone. A very warm welcome to all who have joined here for this session of the ICS Respinars. And today we have a very, very interesting topic. But at the outset, I'd like to thank Dr. Deepak Talwar sir and Dr. Richa and everyone for having me to moderate such an important and evolving topic, which is basically early COPD. Because as a concept, it is still evolving, and we still have a long way to go. So when the task was given to moderate this session, I was a little perplexed, because as a clinician and diagnostician, we all are used to reading the guidelines, finding the evidence and going forward. But here, the concept is so evolving that whatever we are going to discuss today, I'm sure that by the next 6 months or 8 months, we will have more information, and probably a year or the next gold guidelines, we'll have more information and update. And why this early COPD has come up is basically, we will be discussing. But to discuss this, we have an esteemed, experienced faculty with us. And thank you so much, Professor Rajiv Garg, Dr. Tilagavati, ma'am, Dr. Vishwanath, Dr. Vijay, Dr. Bharat for joining in. Professor Rajiv Garg has been in, all of us know that in KGMC Lucknow. Dr. Tilagavati ma'am is head of department in Vijay Hospital, Chennai. Dr. Vishwanath is in Hyderabad. And Dr. Vijay Arvind is MD DNB pulmonologist in Coimbatore GKNM Hospital. And Dr. Bharat is from Hyderabad, Kamineni Gem Care Hospital as a consultant pulmonologist. So before wasting too much time, I think we'll get into it. Can we move to the next slide, please? Yeah. So can we go to the next slide, please? Yes. Yeah. Thank you. So the concept of this, as all of us have now read the gold guidelines, and we know that it is not an update anymore. It is now an evolving. The concepts have changed really. And what we used to think of COPD as some sort of a self-inflicted disease that is caused by smoking or other factors is now changing. Now can we move forward? Next, please. Yeah. So just like any other systemic disease, say for example, a cardiovascular disease, we don't wait for an MI to happen to start treating it. The moment we have features of atherosclerosis, we know that that's the time to intervene. And that is how it should be for many other diseases as well, especially for a disease like COPD, which has a lot of systemic manifestations. And now we know that the need of the hour is to catch it really early and try to halt the natural progression of the disease. And are we really able to do it? I don't think so. So our till now our the goal of the therapies, where once the disease has already been established and a lot of time has already been spent in that disease process. But now we know that even the early childhood, since the early childhood, there is some functional loss in the there is low lung functions. There is a higher risk in those people who have low lung functions. Even in early childhood or adolescence, they are at more prone to develop a lot of other infections and metabolic diseases as well. So that means that there are certain other different environmental or genetic factors that is coming into play. Can we move forward, please? Yeah. So that is, we need to go, as we sometimes say, move more upstreams than going downstreams, the path of the natural progression. So having that concept in mind, we can move forward. Having that concept in mind, there is now a paradigm shift in understanding of that pathophysiology. And now we know and Professor Agesti has also, done a lot of work in this. And now we know that it's a complex interaction between genetics, it's a complex interaction between environment, but that happens over a period of time. And that cumulative effect is what is causing the disease, which means that rather than, catching the disease once it's already there, once it's clinically there are certain processes that might be happening much before in our bodies that we need to identify. And that is where the concept of at a preclinical stage or something has come up. If you remember correctly, like we had an early 2000 and 2003 or 4, we had a concept of goal zero, but somehow it had gone into disrepute, and there were a lot of apprehensions in using that term, because we didn't know how to define it and whether we need to treat it or not. But at least now, as our concepts of new lung trajectories are changing, we now know that there is something definitely that we have missed all this time, and urgent need is there to identify this particular precursors of the disease, which is probably the early COPD or whatever that we will be discussing. But first, next slide, please. But first, this is just to give, no presentation is complete without this. It just gives a fair idea that even from early childhood, there are multiple factors that are coming up that is causing lower, lung functions, and this keeps on transitioning from the infancy to the adult childhood. That means if you're able to catch at very early, at an infancy or at an young adult stage, then the progression of these complex interactions can be somehow stopped. That is the purpose of knowing these in different risk factors. Let's move forward. But before that, moving forward, so early life events is very important, and this particular lung function trajectory is of great importance. Dr. Rajiv Garg sir, would you like to let us all know about the different lung function trajectories, and how is it so relevant in the onset of COPD disease and the topic that at hand, sir?
Actually, what the prevailing understanding of the COPD and what the definitions suggest, that it's a heterogeneous disease. It's a preventable disease, and its diagnosis is based on spirometry. And by the time you catch up with this disease, that is when you have FEV1 upon FVC less than 0.75. By that time already, patient has had structural impairment, patient has functional impairment, and patient has a clinical symptom. Moreover, many patients, what is the slide showing, may have a supranormal lung function. That is, patient does not have FEV1 upon FVC less than 0.75, and more so FEV1 is more than, you might be encountering those type of a patient where you see the FEV1 is more than 100% of the normal. So this is where, and also what you were discussing, the why zero, since zero was abolished from 2007 onwards. The reason was not all patients who had say stage zero, that is a patient who were deemed to be at risk, that is the patient only has a symptom of patient is smoker, having cough and phlegm, and FEV1 upon FVC say preserved, but the trajectory was unpredictable. That these patients, most of the patients said they could not show that they will show the decline in say FEV1 over the period of time, and they will land up with COPD. The different trajectories are there, and because of that reason, because if you see the trajectories, you need to have a longitudinal studies. And now, after the study of the Fletcher and Pito, where the smoking was say very closely associated with COPD, various say longitudinal studies have come up, like Lovelace studies and also Copenhagen studies and other say longitudinal studies. They shows the different, that there is heterogeneity in the say few patients showed that if there is an insult in early part of the life, they may have the decline in lung function, say not say very serious, but few patients may show a rapid decline in lung function. So there is an unpredictable decline in lung function as far as the different longitudinal studies has shown, and that is why our say perspective, our vision of say seeing towards this disease has definitely changed over a period of time. To catch up these patients early, because by the time if you catch up the patient later on in the life, we are not going to change the natural course of the disease. Because if we want to change the natural course of the disease, we have to catch up the disease at the early stages.
Absolutely, sir. Absolutely. Thank you so much. Tilakavati ma'am, would you like to add on something in terms of, because there are two ways in which the lung function deteriorate. It can be either an abnormal lung development, or it can be a fall in the lung functions, a rapid fall. So what do you have to say regarding the rapid fall, ma'am? And this catch-up phase, as we see in the puberty or adulthood, where they are supposed to achieve a peak, but some people don't. And then, or even if they do, they are not able to sustain that peak. Ma'am, would you like to elaborate on that in the context of identifying early COPD?
I would like to thank the organizers, Indian Chest Society, and everybody here for giving me this opportunity. Thank you. Ma'am, regarding your question, I think the lung trajectory is not normal in every individual. So if it is normal, and if it is if you can catch up this disease early and change this trajectory, that is what this early COPD is all about. So it starts from prenatal, perinatal, childhood, puberty, like say from maternal smoking to post low birth weight to environmental exposures, socioeconomic status. So various factors at various parts of the trajectory act on this genetically predisposed people. So genes plus the environment. So at every stage, if you catch them early, so I think you can change this trajectory in which they follow. So catching the patient late in the trajectory where there is a lung function decline already and there is loss of lung function does not help much. That's what this COPD, new COPD goal 2023 is all about. I think all of us need to wake up, act early, I think most of my practice in the tertiary care is where I see patients in the gold stage 3 category, where nothing much can be done. Where in the earlier trajectory, if we have found out these patients, I think we can make a difference in their life. So identifying this early COPD is the new concept. I think all of us should have awareness, spread it across the country among all physicians everywhere, where you start early, catch these patients early, and then give them a normal lifespan and a good lung function.
Absolutely, ma'am.
Each trajectory, there are different etiologies where we need to address different exposure. It is mainly symptoms, risk factors, and lifestyle change. These three things at each trajectory have different, for each patient is different, and for each group of patients also it is different. It's individualized, and we need to identify and address these things.
Correct. Very succinctly put, ma'am. And that means we need more, surveillance studies, basically, and also right from the when we take our history, I think it's for all of us, like very early childhood changes, recurrent infections or low birth weight, or any child has, can have an impact when the child is coming to me at 25 years of age or 30 years of age. That means those are the things that also we need to keep in mind when we are taking history, that these would be at risk population, especially in the context of pollution or smoking history. And these are at risk patients who tend to develop probably COPD. Thank you so much, ma'am. So we'll move forward with the next slide. So the next slide is also same, this slide, please. Just click on, please. Just click once more. Yeah. So given these trajectories, the green box is where all our focus has been so far, as ma'am has rightly put. But we do realize that by the time we are, seeing these patients and diagnosing these patients, we have really lost the battle. They are already in a progressive disease, and nothing much can be done beyond this point. And that is why, the need is basically this pink zone where there is most of the preventive secondary prevention that's happening. And Dr. Vishwanath, your inputs regarding this zone, and do you think that this peak and plateau, can we define it in some way? And what is your viewpoint in this aspect? Dr. Vishwanath, please.
Yeah, thank you, Dr. Vijay. And lot of valid points given by Dr. Rajiv and Dr. Tilagavati. So as we can see in the graph here, in most individuals, normal individuals, the peak lung function occurs at the age of around 20 to 25 years, in the middle box, as you can see here. Okay. Yeah. And suppose if the normal decline is say 30 ml per year in a normal healthy adult, as you can see here, there are graphs. The dotted lines represent the lung function decline over years.
Yes.
With increasing age in smokers, actually. So it's very clear for all of us from the Fletcher and Pitot, from the time we start reading our COPD concepts, we read this actually. So the lung function decline in smokers is greater than the normal individuals. This is what the both the upper and the dotted curve indicates. And coming to the graph which is below, some of the individuals, as you said, when they had a prenatal insult, low birth weight, or a childhood event in the less than 5 years of age, these patients actually have a low lung function to start with. And over that, if they start smoking again, as you see that their lung function even further decreases further, actually.
Yeah.
So we also know that if these patients suffer an acute exacerbation, again, the lung function decline is even more greater, actually.
Yes. So recurrent episodes of insult can again add on to the issue which is already there. Yeah.
So it's important to identify this concept because a lot of times as clinicians, we hesitate to make a diagnosis of COPD in young adults. But we should understand that when the patient starts with a low lung function to start with because of some insult, and they have a smoking insult over that or some other insult, environmental exposure or any other thing, these patients still have a high risk of developing COPD. And then rather than labeling as bronchial asthma or something, actually we need to study these patients gradually over a period of years and then see whether the lung function is getting reversed with LABA ICS. A lot of these patients are actually started on LABA plus ICS and treated like asthma rather than a COPD. So we need to see whether these patients all have paroxysmal symptoms or not, reversible obstruction or not. All these things will help us making a diagnosis of COPD even in the younger age group.
Yes. So that also means that the kind of terminologies that we are used to in many of these studies also, that sometimes we interchange mild COPD as to be trying to say that it has occurred in a young individual. And that kind of, mix and match of terminologies is very confusing. And can we move this slide, please? Can we move? Yeah. So this means that now, so we need new nomenclatures, and there is a need of lot of nosological, terms, because a lot of it is adding to confusion. So the next slide we have, now we have some definitions at hand that we can discuss one by one, as early COPD. which is basically what they're trying to say is biological early, which means that the patient has not developed symptoms. Dr. Rajiv sir, would you like to go ahead with the first early COPD?
Definitely. Actually, the early COPD, if you see, is within a time frame.
Yes.
Okay. Whereas and that is where the biological early they have tried to incorporate in the new nomenclature as far as goal 2023 is concerned. As far as the mild COPD is concerned, whatever we say categorize, they are this severity category. That means actually it is the limitation of the definition. What is the current definition is? Limitation of current definitions is based on spirometry, and that spirometry itself, when we catch that patient, it is basically it is a bit late. So
yes.
When our objective is now, people are thinking in those lines that what you have said in your introductory line, that look, we have to catch the disease when its symptoms has not appeared, because if you want to say change the course of the disease, then we have to catch at that. So early disease should not be confused with the mild disease.
Yes.
First of all, because when we say a mild disease, that means the disease has set in already, and this when the disease has set in, that it has to be in terms of the severity grades. So
yes.
when we say early, that means it is in the time frame. That is the time frame that patient may be, that you may have a patient, you may encounter a patient who is 60 years of age, who is a smoker, but who has a preserved lung function, that is FEV1 upon FVC is more than 0.7, and if you follow that patient, maybe his FEV1 is say declining. If you follow that patient down the line of 4 years, so you may feel that patient has say decline in lung function say over say 4 years, but it is not true. The truth is, this patient may have developed the disease pathology, or the pathogenesis of disease has started or set in a bit early. So first thing what I want to say, that early COPD should be not a clinical mild COPD. It's an early COPD, which is a biological early. For this, we are searching still what are the biological agent, what are the biomarkers which can be.
Yes,
and likewise, mild
COPD.
Mild COPD is a term which has a mild airflow limitation, and so on.
Yeah. Can we move the slide just one bit? Just one click. Yeah, thank you. So as Dr. Rajiv has already mentioned, I have put in that it is for all of us to understand very clearly that biological early, when we are talking in terms of research and all the articles or all the studies that we have so far, they are identifying biological early, which is different from the clinical early, just by saying that a patient has developed a symptom. So that is clinical early, but biological early is to identify the pathophysiology at a very nascent state before the patient develops the clinical illness. Ma'am, would like to know your thoughts regarding pre-COPD and early COPD, pre-COPD. Are we adding on to more confusion, or are we refining it more? Ma'am, your thoughts. As pre-COPD, we have a lot of studies. Early COPD, very difficult to define. Ma'am, your thoughts on pre-COPD, please.
I think Gold has given so many definitions to make people understand that you need to pick up these disease early. That's the concept. Yes. So, so I think early COPD really means, according to me, you catch the COPD before there is loss of lung damage. It is related to the biological disease activity. Yeah. You can call it biologically early, physiologically early, or chronologically early also. Okay. But how are we going to catch these patients so early is the $1 million question. So yes. Any definition of COPD is related to 1, symptoms, respiratory symptoms, 2, structural damage in the lung, 3, physiological parameters in the form of spirometry. So you need to incorporate all these 3 parameters to define a COPD, any form, be it mild, be it young people, be it pre-COPD. So if you have these 3 parameters in your hand, you can define COPD. So the mild COPD is actually the gold stage category where impairment of FEV1 is considered, and it is a mild COPD. This is already established COPD, and by spirometry, you're calling it mild due to airflow limitation and according to the criteria. So that is a different thing. Early COPD is just biologically early. COPD in young people is just in the name. It is in the young people between 20 to 50 years. They can, independent of whether they have airflow limitation or whether they have symptoms or whether they have structural abnormality in the lung. Pre-COPD is actually, again, coming to the definition, pre-COPD incorporate the symptoms, respiratory symptoms, structural function, and the physiological parameters. Here, pre-COPD patients have respiratory symptoms, they have exposure to risk factors, their spirometry is normal, but you can detect some structural or functional abnormality like small airway disease or emphysema, and their total lung capacity is increased, their DLCO is decreased. So it can happen at any age. They may or may not develop COPD at a later stage. Okay, but I think catching these patients in the pre-COPD, like 50% of them can progress to COPD. That's what the studies are coming up. I think we need more data to really see what this pre-COPD helps us. And pre-COPD is just like saying pre-diabetic. If you have a pre-diabetic, what they do, they put an Apple Watch, they run, they reduce the weight, they do so many things so that they don't develop into diabetic. I think that amount of effort should be put into patients who are pre-COPD patients and asking them not to progress to COPD, where it becomes very difficult when we see them with COPD from disease.
So all these points, we have certain, other research articles that we'll be talking about also very briefly, because all of these points have now shown that they all are some sort of a precursor to a disease. It may or may not happen, but if it happens, it can be disastrous. So we need to identify them. The problem with early COPD and pre-COPD is that there is no, tangible way to diagnose it. At least pre-COPD has some points or observable factors like some structural changes in the presence of clinical symptoms or things like that. But in early COPD, these because it is at such a nascent stage, it is very difficult. That means we need more biomarkers. So moving forward, Dr. Bharat, can we go ahead, please? The next slide, please. Yes, there are few other definitions that Dr. Bharat, would you like to start with the disease activity, basically, which means that it's basically trying to understand the pathobiological process. And would you like to
yes,
your opinion on these?
Thank you for giving me this opportunity. Am I audible?
Yes, absolutely.
Yeah.
So Dr. Bharat and Dr. Arvind also will like to join in with these 4 preventive points and the disease activity and progression aspects.
No, disease activity, coming to disease activity, you have seen what early COPD is, what pre-COPD is, and how important catching pre-COPD and early COPD patients is. Now, regarding this catching, it is we have very few tests to know. Spirometry is not reliable. We have seen in all these slides before that spirometry is not reliable. So disease activity relates to a biological term. It relates to the pathological process endotypes. It can be identified by validated biomarkers, but currently as such in COPD, such biomarkers are not so much validated. So if we can find these biomarkers, it will be very helpful in catching these early COPD patients and stopping the progression of disease. In this way, and disease progression is a term that refers to progressive deterioration in an objective marker of pathology or lung function. So this is either be it with spirometry or the pathological markers, be it by other tests like small airway disease or DLCO. In those, we can objectively see the disease progression.
Yes. Dr. Arvind, would you like to comment upon the preventions that we have new concept coming up, especially focusing on the secondary prevention, which is basically identifying these early stages?
Thank you. So I will emphasis on 2 points. Number one, we are talking about this pre-COPD or the PRISM group, where patients are at risk of having COPD, but they are not showing much evidence of obstruction in the spirometry. So Talking about India secondary, where we have a significant more people who are smoking, and there's also significant amount of biomass exposure. So we have to identify these are the risk factors in those patients and ask them to stop smoking and prevent them from having that biomass exposure. Regarding secondary prevention, that is treating the patients with say bronchodilators or inhaled corticosteroids. So whatever studies we have, actually, I would like to emphasize on the Rethink trial, in which we took patients of the PRISM group and we treated them with, say, LAMA and LABA combination.
That we will discuss in the ahead, Dr. Bharat. My thing was basically what they're trying to say is secondary prevention is basically identifying the disease before and treating it or halting the progression. So again, same that the evolving ideologies and the evolving concepts basically now says that secondary prevention is basically nothing but trying to identify a pre-COPD or an early COPD. So, and then managing it, as you rightly said, with Rethink trials and other things we have that we'll be discussing in the future. Thank you. Thank you so much. Would you like to add on something as far as the early COPD or pre-COPD is concerned? Yeah, muted.
Ma'am, we'll move on, ma'am. We'll discuss.
Yeah. So so at this point, please.
Actually, the whole, if you see, the COPD is a disease now, whatever the current understanding is, we have the role of primary prevention, we have a role of, say, secondary prevention, we have a role of tertiary prevention as well. Primary prevention, the evidence are the COPD can start in utero as well.
Yes.
The mother who smoke, so their offspring, they do not attain the normal lung function. Actually, lung is the organ which keeps on, say, developing, and the peak lung function is attained at the age of 25, which we are discussing through the trajectory. So primary prevention, when the mother doesn't smoke, the smoking cessation. Secondary prevention, when you detect it early, you treat it early. Tertiary prevention, when already the complication has occurred with the treatment, you have a role of rehabilitation. That's what.
Yes.
That's from my side.
Yes, absolutely, sir. You put it very correctly, and that is the point that I wanted to come. Can we move forward, please? So now we know that we needed to identify it, and but how do we identify it? So as a concept, we need to find certain symptoms or certain CT findings, probably, or certain biomarkers to actually label it as, okay, this is the subgroup of patient. So we have a lot of data, and when we go into the data, we find that if we were to use symptoms, and what are the kind of symptoms that we are seeing in the early COPD and a lot of other cohorts and population-based studies, we feel that the dyspnea may not be a very predominant feature in these patients. However, cough and phlegm production or mucus hypersecretion has been noted across so many, population-based cohorts, especially the ECRHS, the European cohort, as well as the Spaldia, which was Spanish, that the chronic bronchitis features and a lot of cough and phlegm production was seen as a marker for disease progression ultimately, and that their incidence in these COPD groups were much higher, which could mean that, to identify an early COPD, if we surveillance these patients who have a lot of cough and phlegm and chronic bronchitis changes or symptoms as these with a smoking history, that might be of help. And probably so that is why in the gold right now, we are the earlier concepts that when we used to study of chronic bronchitis and emphysema are coming back in a long way, and they are understanding chronic bronchitis, emphysema, and as well as small airway obstruction, because these are the backbone of the pathophysiology of COPD. And now the researchers are understanding that we needed to identify them as quickly as possible and probably try to, manage these symptoms and identify them. Dr. Vishwanath, would you like to share your thoughts, or anybody? Ma'am, I think ma'am wants to say.
So just wanted to add a couple of points actually. So
Yes.
there was a question about whether pre-COPD and early COPD are same. Just I would like to clarify the question. So
Can we take the questions later, because I think we'll have a lot of time. I think we can come back for the questions later.
Yeah.
Yeah, and it's a valid question. I saw that Dr. Vishwanath will be taking this question. And so moving forward, we have these symptoms as well as, the physiological measurements, what all can be done. Can we move forward one slide, please? So I think we can discuss this point. Can we move one slide, please? Yeah, thanks. So basically, in the Lovelace smokers cohort or the New York smokers cohort, there are multiple cohort studies which felt that the rapid fall in FEV1, that is more than 40 ml per year or greater than 60 ml per year, was very significant in identifying the disease progression and whether this fall of FEV1 can be used in identifying. So the pros and cons of this using this modality, Dr. Vishwanath, if you could, say, because in the context, see that when we are talking about early COPD and we are saying that they have preserved lung function, and if we are trying to identify a progressive fall, how are we going to measure it, whether it is of value to us?
So one of the important group which has defined this early COPDs from the Martinez study, which was published in 2017 actually, wherein they have identified patients who were not symptomatic, but they have identified patients who were at high risk of developing COPD. So they have defined these patients as having early COPD when these patients were less than 50 years of age and also had a smoking history of more than 10 packets. Plus any of the three of these things. The patient was either having an accelerated decline, as you were telling. Actually.
Yeah, that we will talk. Yeah.
Or these are all the criteria of this Martinez actually. So what they have said is age with the smoking history plus one of the following: either accelerated decline more than 60 ml per year, or an FE1 by FEC less than lower limit of normal, or this CT scan showing some kind of structural abnormalities like air trapping or emphysema. If any of these three is present, these people were defined as having early COPD.
Yes.
And again, in these patients, they have seen that these patients,
Saurabh, can we move forward with the slides? We have gone ahead actually. As Dr. Vishwanath is saying, I think put in those definitions. I wanted to discuss the use of this lower limit of normal as well as fall in FEV1, whether how good it is to define this kind of physiological measurements. So in that aspect, can we move forward, Saurabh, to the slide which is showing that what Dr. Vishwanath is talking about, so that it will be easier for all of us. Dr. Saurabh, Mr. Saurabh, I think you need to move forward. So these are the multiple trials that were early on, which it was helpful in, identifying what the Martinez study, the milestone study that is identifying. So next slide, please. Next slide. Yes, this. So we all can discuss, and Dr. Vishwanath, you can continue from here, and we'll ask all our expert panelists for their opinion on this.
So since these patients do not have actually symptoms, it's very, very important to identify these patients before they actually develop clinical COPD. So these are the criteria given by Martinez actually in 2017, wherein these criteria helped us identifying these patients in a very early stage actually. There are various kinds of definitions for defining early COPD, but this is one of the important definitions and has been used in like a lot of other subsequent studies as well. So as you can see here, the age, the risk factor, that is the smoking history, and in the minor criteria, you have this either one of these three should be present actually, that FE1 by FEC less than lower limit of normal, emphysema, air trapping, bronchial wall thickening, or accelerated decline. If any of these things is present without symptoms, then we can label these patients as having early COPD. Because if you see in the general population, actually as the age increases, in these patients who have these early COPD features, they actually start having COPD kind of symptoms actually. They progress and some of them go on to develop COPD.
Yes. Dr. Rajiv sir, your opinion?
Yes, definitely. Actually, what COPD has actually been related with the accelerated decline in lung function.
Yeah.
So, and also it is felt the disease of the aged. The
Yes.
one study which reminds me of, say, which was published in NEJM 2015 by Peter Lange. If you read, for the PGs who are listening, who may be interested, it's a very good study. They have, say, compiled the data of the three cohorts, that is the Framingham, Lovelace, and this, which suggests Copenhagen, which suggests that it is not the only rapid decline which is, say, responsible for the development, but the lung function. If the persons who do not attain the lung function, irrespective of the smoking status,
Yes.
they also develop the COPD.
Absolutely.
And then Martinez come out with
Yes.
this
Yes.
idea
Yeah.
where he has, but the problem with Martinez definition, it is yet to be validated in, say, large number of population, because,
Absolutely.
say, to see the change of 60 ml, to see the CT changes, but definitely what all these studies suggest, that yes, COPD is not only a disease of elderly. COPD is not a disease where the rapid decline in lung function is there. It is somehow we are something missing in early part of this disease. We are not looking for the. We still have to learn about the
Yes.
pathogenesis and the pathophysiology of this disease.
Absolutely, sir. Very rightly put. So my issue with the fall in FEV1, as sir has also pointed out, is that that might not be. This is only seen in 50% of the patients. So we are missing the other 50. Secondly, all these patients, when we are talking about early COPD or pre-COPD, they all have good lung function. So the rate of fall will definitely be more, because when you are starting at a highest point and it is falling, the rate of fall will be more. So the issue that I wanted to bring across is that the fall in FEV1, though looks very lucrative and makes sense to me, that yes, if there is significant fall in FEV1, that means the disease is progressing and without symptoms you are able to catch it, then we will be able to sort of identify them. But that might not be the case, and that is why, as Dr. Tilagavati rightly said, trying to identify CT factors, or early or pre-emphysema stage, or CT features that will pick up early bronchial wall thickening or air trapping, is very, very important in this population, and we'll be talking further. So this was the study that sir was talking about, which used the Martinez. Next slide, please. Next slide, please. Next slide, please. Yeah. Dr. Bharat, this was the study that was used for the same criteria was used by the Martinez criteria, where what they did was they just went into a general population study. It was done in Copenhagen, and about 1 lakh adults that they took information. So at the baseline, they had these many people, and they tried to find out what all people had smoking exposure and what all patient we have some baseline FP1 by FVC values or not. So if the ratios were less, which means that there was already obstructed or airflow limitation, they were removed from this study. And the rest, 89,000, they found out that and who had a preserved lung function as per the FP1 by FVC criteria, and smoking information was there. These patients were then defined as per the early COPD as having FE1 by FVC that is less than the lower limit of normal.
Yes.
Okay. So now, and at the end of these 10 years, this was a 10-year study, and they were progressively looking at these about 5,497 people at the end of the study who also had these values. And all these patients were the age of less than 50, which gives us a good idea that yes, this could be a subgroup of patient where early COPD features could be identified. And they were also externally validated with the other Copenhagen Heart City group. And can we move forward, please? Yeah. So, Dr. Bharat, would you like to look into it and say that, look at the incidence of, COPD at, the baseline, no early COPD at baseline that were about 5,329, and early COPD was identified as 168.
Yes,
and these, yeah. So, like to have any comments? Can we move forward, please, to the results? Yes. The next slide, please. Yes. So we'll discuss about the relevant features here. So early COPD was seen in 4% of smokers that were having greater than 10 pack years, and 3% of smokers with less than 10 pack years, and 2% in never smokers as baseline. And amongst these smokers, there was 24% developed clinical COPD at the final examination, which also meant that identifying that group of patients, and 24% of them actually developed COPD. Dr. Bharat would like to have your comments and opinion and using this criteria and to identify these patients.
Yes, ma'am. As we have seen, this was a longitudinal study. The Copenhagen study was conducted over a period of 10 years. It was a nested cohort study, and patients were followed up for a period of 10 years. And they have found that what the key takeaway from this study is that patients who had smoking history of greater than 10 pack years, a significant proportion of patients develop COPD earlier in the age, less than 50 years. But traditionally, we think that COPD is a disease of more than 40 years or 50 years. You have a long smoking history. But in this study, highlighted that even in the early stages, we can find changes of COPD in these patients, even before 50 years.
Yeah, very good. So next slide, please. Yeah. Dr. Arvind, the fact that, the baseline, the early COPDs had a lower lung functions and more frequent symptoms. Dr. Arvind, are you there?
Yes, ma'am, I'm here.
Yeah. So, and also on the point that and greater than 60 ml per year was noted in about 8% of these patients. Your opinions and thoughts on this?
These are very significant findings for all of us to understand that this concept of early COPD, which we have identified them at a very early stage, and we have to treat them at the earliest.
Yes. Moving on to the next slide, please. Ma'am, so the study did, pick up, it had a very good specificity. Tilgavati ma'am, can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah, ma'am. So even though we have some hope that were able to identify this COPD, that was the hope of starting, and the studies and the progress, the cohorts were shown. But looking at the sensitivity and specificity while using these sort of criteria, ma'am, your thoughts regarding the specificity and the sensitivity and what it really means. Basically, if we mean that the negative predictive value is high, so basically we are saying that whether are we able to identify COPD later on in life or not. Ma'am, your thoughts on this?
Yeah. See, actually, COPD is not that simple to, and we are talking only about smoking, where we are, goal 2023 has moved. Say, smoking is only one part. You have so many other environmental factors, biomass pollution, other cooking gas, so many other exposures are more now. So, for example, see, it's a long process. COPD has a long incubation period, basically. From chronic inflammation to injury to repair to structural remodeling of the respiratory tract, and then you detect the pulmonary function changes. So lungs structural changes come before these functional changes, as you rightly said, in the form of small airway disease and things. But what happens when a patient develops symptoms, respiratory symptoms? That's what we're talking about in early COPD. When they develop early respiratory symptoms, they ignore what we do. What humans tend to do is they tend to adjust to that distinct symptoms, and they don't come out with those symptoms. So basically, they become inactive, they become deconditioned, and then they set a new normal, thinking that is they restrict their activities, and then so early COPD is about catching those patients there. So I always feel there should be a proper question. You should ask the right question. We should not ask the wrong question. If you ask the patient whether you have dyspnea, they will say no. So we need to catch them that early, even before the structural change happens. So it's like you need to have different dyspnea questionnaire, or you need to ask the right question to the patient. If you ask them, are you dyspneic? They will say no. But if you ask them whether you are able to do an activity, gardening or playing with children, what you did last year, they will say, I'm not able to do. So you need to pick patients. They will not come out with these symptoms. So such early picking up of symptoms only can change this trajectory, because we know that smoking cessation actually changes the trajectory on how the lung function falls. So I think in this group of patients, though there is all these studies with so much pack years, even biomass, you can, if you have to equate it with the biomass fuel exposure, I think that also we need to add. So basically, catching an early COPD is a very difficult task. I think we need to change the approach how we look at. So can we have some more dyspnea questionnaires which are very friendly, which we can help these patients early at the primary level so that they don't come to us with some structural lung damage. I think that's where we need to work on.
Yes, very rightly put, ma'am. So we need more composite scoring system rather than going with one or two points of say symptomatology, or as far as the spirometry is concerned, or as far as the PT features are concerned. However, this study did say that the negative predictive value was so high that it was able to say that whether this patient is going, if we are not developing COPD or not, that was able to be able to identify with the existing criteria of Martinez. However, it did not pick up a lot of early COPD patients. So that was the limitations. Can we move forward, please? So the limitations, Dr. Rajiv sir. So there are few things that we were noted was post bronchodilator spirometry was not used, and these patients, Dr. Bharat and Dr. Arvind, if you can chip in, everyone on the limitations of these studies and the what your perspective on it.
Actually, what this slide doesn't reveal any new thing. Actually, what if patient is a giving history of smoking, not every smoker is going to develop the COPD. So the sensitivity is less and whosoever has developed COPD, yes, definitely will have a history of, say, smoking. That's what we can say, take from the earlier slide as such, and that doesn't anything new as far as the understanding of this COPD is concerned.
Rightly said.
But definitely we are still searching and hunting for the early COPD cases, which is still the far.
I think the point is, if we are able to change our criteria, then these numbers are going to change. That's the whole point of it. So rather than getting disheartened that it was not sensitive, our approach should be to find more and more refined biomarkers. Can we move forward, please? We'll move forward. So we have already discussed these points, and this was another study, again same results basically, but this study also picked up the early COPD, and they try to identify the symptomatology in these group of patients. But it is very surprising to see that the patients who had no COPD, out of that a good chunk of people were still symptomatic, which meant that we were really missing. When you diagnose as no COPD at a later stage of say 10 to 12, and when the preserved lung function patients they called as no COPD, the symptomatology was still very, very much present. So we are missing a big group of people who are actually having an ongoing disease process, but we are not able to label them because we don't know how to label. Similarly, in the early COPD group, if you look, of course, there were 386 were asymptomatics, but the patients who were, the more patients who are having symptoms. That means our criteria or the points that we are using to measure the early COPD is definitely not correct, is what I wanted to pinpoint in this particular group. Next slide, please. Also, this study had a prognostic value. So if we look at the graphs, we can very clearly see that in the groups of early COPD versus no COPD, over a period of follow-up of 15 years, 10 years plus, there was a very significant, the p-value is very significant in terms of the hospitalization risk. It was definitely much higher in early COPD group. Not only the acute, exacerbation hospitalization, but also pneumonia and the all-cause mortality as well, which meant that even though our defining factors may not be that refined, but whatever we could identify, this subgroup of patients definitely had a bad outcome or a bad prognostic indicator, which means that we have to start acting early, and we need to have some treatment as far as things. Very briefly about the PRM imaging modality. Next slide, please. Next slide. So this is, again, we have already discussed. Next slide, please. Next slide. So these are the existing diagnostic modalities we have to diagnose early disease. However, there are no standardizations or validated thing to identify. And Dr. Rajiv has already, said that all these things need to be, validated and standardized. And we do not have that in process, and that is a big loophole in our understanding. So moving on, next slide. But very briefly, that this looks promising. And this is the PRM CT modeling where, the inspiratory and expiratory scans are fed into a computer, and the algorithm processes it into 3 distinct groups. And this classifies them as a green, yellow, and red, in these pictures. And green is basically normal. Yellow is somewhat, we say, is a functional small airway disease. And the red is emphysema. Also, it is very important that these are the group, and most of these studies have been standardized and published, wherein when the patients have not, where they have a normal PFT on spirometry or a body box, when they underwent the CT scans, and we were able to identify these group of patients. So therefore, this PRM holds a good place in the diagnosing, early COPD, because this is able to pick up and, and comparative with the, and in a long-term follow-up, we are able to see that this group of patients, if we are able to identify and follow up them up for the next, whatever, 5, 10, 12 years, and then we are able to see whether they actually develop the disease or not clinically, is going to have a very good prognostic value. So just briefly, next slide, please. So we have 2 more articles, and in China, again, the concept of early COPD and the clinical features and the 1-year outcomes of these patients. And they have also found and said the same thing, that we need to pay more attention in identifying the non-obstructive chronic bronchitis. Dr. Rajiv Garg, sir, your thoughts on non-obstructive chronic bronchitis, now that we also have now in the goal guidelines this concept, and there is a lot of, importance being given to it. Sir, your thoughts on this?
Actually, we are going to the backwards, where we used to teach that COPD has got 2 spectrum. That is, one is this chronic bronchitis at one end, and the another end is emphysema. Actually, chronic bronchitis, now it is being recognized more and more. The patients who have the increased amount of, say, sputum production, phlegm, mucus, they have the more risk of, say, developing rapid decline in, say, lung function deterioration. And these are probably the patients who were, say, categorized as gold 0. The patient will have, say, cough, patient will have phlegm, but the patient will have a normal lung function. Or somebody was asking, but what now we are, say, labeling as PRISM, that is a preserved ratio, that FEV1 upon FVC is normal, but somehow patient may have either abnormal FEV1 or patient may have abnormal FVC. These are the patients who are likely to have, say, maybe patient may have FEV1 upon FVC equal more than 0.7, but the FEV1 will be impaired. These are the patients who have got NOCB, that is non-obstructive chronic bronchitis patient.
Yes, very rightly said, and very important concept of PRISM also. Preserved ratio impaired spirometry growth. It's an entity in itself, and just like early COPD, it is also a cohort that is being extensively studied. Whether we need to treat them or not is a question that is debatable, and a lot of evolving concepts are coming up, and we are still in a way to identify and manage them. Moving forward, please. Next slide, please. Yes, so the rethink study that Dr. Bharat was talking about, Dr. Bharat would like to take this point, because now we know that these early COPDs needs to be identified. So if you look at the data for as far as the therapeutic trials are concerned in this group of patients, say the early onset disease or patients who are smokers with preserved lung function, because that's all we know so far. We are not able to identify early COPD very objectively. So what does the rethink study group say? Dr. Bharat?
Yes, ma'am.
Yeah.
We know that in early COPD, a lot of patients have mild respiratory symptoms, like maybe cough or mild CAT score. We can define it as CAT score less than 10. In these patients, although spirometric abnormalities are not found, but these symptoms, early symptoms can be found. And in this study, they were randomly assigned patients into either indacaterol or glycopyrrolate or placebo twice daily for 12 weeks. And the primary outcome was at least for 4-point decrease in the SGRQ score.
Yeah.
And 128 of 227 participants in the treatment group and 144 of 244 in the placebo group had a 4-point decrease in the SGRQ score.
So basically, was not very good. We were not able. There was no benefit given by giving. That was the. Can we move the slide, please, ahead? No, last, yes. So dual therapy here was the study did not, say that it did not have a much benefit. But giving it for 12 weeks was not a very nice thing to say, because 12 weeks is a very short time for any assessment for therapeutic implications. And also that what kind of patients we are treating and what we are treating is also very important. So I think we should not get disheartened with the Rethink study group. We need to redefine what we need to give and what we are trying to treat. That is the main point of it. Next slide, please. So few other studies that have been done that have been little bit, shown that yes, especially the uplift, the subgroup analysis, which did show that when we give tiotropium, the FEV1 decline was, reduced by 20 ml. And the lung health study group, which showed that while we give the LAMA as ipratropium bromide in patients who had an preserved lung functions, there was an FEV1 increase in the first year. But however, once the medication was stopped, it again reversed. So there was some hope that early intervention was helpful. But in all these research trials, the criteria or the inclusion criteria for these patient characteristics are very, are not as per the our concepts of early COPD. So, Dr. Arvind, your thoughts on what kind of, what can we do for the therapeutic trials, because we have nothing at hand at the moment. And
after hearing from whatever trials you have spoken about, I think it is time where we have to move one step ahead and do further investigations, as you are talking about, like a CT scan or an impulse spirometry or a DLCO with a lung volume, to prove that there is evidence of an airflow obstruction, and then to start treating them accordingly. Because this subgroup of PRISM or pre-COPD, we don't have any evidence of obstruction in them, but we found in the study that they were treated with only bronchodilators. They were treated with a combination of LAMA plus LABA. Yeah. So we have to identify in those subset of population, what are the group of population which exactly have an airflow obstruction, which has to be prone by some way or the other, for which you need some other evidence, ma'am.
Yes. Dr. Vishwanath, your thoughts on, there might be a lot of, patients who are already being treated with bronchodilators, where we don't have PFTs, and just based on the symptomatology, we are treating them. So your thoughts on this kind of therapeutic trials that are being done? So, Dr. Vishwanath?
Yeah, these patients where we don't have actually obstructive defect on the PFT, I think it's better to label them as COPD-A and then start them on just SOS therapy rather than regular inhaled bronchodilators, because in this subset they have not shown much benefit. So unless we have evidence from the spirometry, don't start them on treatment. Maybe rather encourage them more to go for a preventive sort of thing, smoking cessation, vaccination, annual vaccination for these and other things, rather than starting the inhalers upfront.
Absolutely. That was the point that we wanted to make.
Can I add on, ma'am?
Yeah, please. Yes.
Ma'am, I would like to add that these patients should be having a very regular follow-up with frequent spirometries to observe the fall in FEV1 as well as clinical condition, to assess when do you have to start this patient on bronchodilators.
Yeah. Yeah. So these patients need surveillance. That is the most important thing, and primary prevention with smoking cessation and environmental changes. Yes, very nicely put.
Can I make
So
a point, ma'am?
yes, ma'am. Please go ahead.
So this all this rethink and all those studies are done on pre-COPD and PRISM patients. There is
Yes.
one more study called Rotterdam study where
Yeah.
they found that over a period of time, 1/3 of these patients developed cardiovascular disease, and 1/3 of the patients died due to non-COPD causes like cardiovascular morbidity. So
Yes.
this actually this spirometry and this picking up these patients in early COPD is just an indicator of your global health.
Absolutely.
So it is an all-cause mortality.
Yes.
Next,
Yes.
coming to this pharmacotherapy and this bronchodilator, I think from one bronchodilator, dual bronchodilator to everybody will do the bronchodilator therapy well. It doesn't matter at all. What
Yes.
matters is the avoiding the risk factor, moving away from the risk factor. So crucial. Stopping smoking is most essential. And the next important thing is endurance training and exercise training and nutrition. The next is body mass index. If your patient has low BMI, improve the BMI. High BMI, bring it down to normal. So many other factors matter. It doesn't matter whether you give one bronchodilator or the other bronchodilator. It matters all the other matters because all cause mortality in these patients are very high. So doing this spirometry, pricking these patients early, one part of the arm is avoiding COPD development. Yes, agreed. But it also has a global, it is an indicator of global health.
Absolutely, ma'am. This point has been brought across in the recent updates, and also that as a global health, we need pulmonary function test can be used as a marker of global health, just like atherosclerosis is. Very rightly put. Moving forward, please. Moving forward. Next slide, please. Next slide. Yeah. So again, we have already discussed it. We can move forward. All these, different studies have just shown that there is these patients are at risk of developing respiratory issues in the future. So the knowledge gaps, I think it is open to all. Dr. Rajiv sir, I'd like to start with you. That of course the need to change the direction, and ma'am has already put the point that I put it on this slide, is that smoking cessation and preventing infections, vaccination, nutrition, and diet is the most important thing. And ma'am has already said that. And coming to the aspects of the NOCB and pre-COPD, we have discussed that. And Dr. Vishwanath, you would like to take this, as there is a question as to difference between early COPD and pre-COPD. Dr. Vishwanath, now is the time. I think we can address that question that is there in the chat.
No. So the question was about early COPD and the pre-COPD. In early COPD, as was pointed earlier, actually, it's basically more of an early pathophysiology. It's to identify the early pathophysiological process, what is going on actually. These patients actually have not developed COPD and they're at risk of developing COPD. Okay, these patients have to be followed up closely, but there are no clear-cut criteria to identify these patients. Coming to the pre-COPD, these patients most commonly we see in our clinic. Sometimes we as clinicians hesitate to make a diagnosis of COPD. They have some symptoms. They have some structural abnormalities. Sometimes they have some emphysema or bronchial wall thickening. And also if you do an spirometry, they show like a low FEF 25/72, or if you do an impulse oximeter, you can find that there is an evidence of small airway disease in terms of R5 and increased R5, R20. But they do not have a clear-cut spirometric criteria of FE1 by FEC less than 0.7.
Yes.
So these are the patients which are called as pre-COPD. They don't qualify for spirometric criteria, except that they have got everything. They might be having structural abnormalities, symptoms, and everything. So these are the patients actually whom actually our efforts also, it's like a sort of secondary prevention actually.
Yeah, totally correct. So yes, we have to identify pre-COPD, and these patients have to be managed as per their symptoms. And we need to keep on repeating the pulmonary function test or other tests that we have pointed out in these slides. If we are able to identify the small airway disease in these patients, then we can actually treat them and manage their treatable traits. And all of these patients tend to have, especially they are young population, and all of studies have really shown that these patients, they have more of a mucus hypersecretion. And mucus hypersecretion is in a separate entity, and it has been as a prognostic marker, because these patients tend to have a worse outcome as far as their COPD natural progression is concerned. So we need to identify and manage these patients, and that is why the goal this time has come up with the non-obstructive chronic bronchitis features. They're putting it as an entity, and we are trying to identify how to manage these patients. So that apart, the identification of small airways is also very important. For that, we have two aspects. One, we have the spirometry aspect, which we know that we are not able to pick up the small airway disease. For that, we have the forced oscillometry techniques. And but as far as a global, surveillance or a guideline is concerned, these kind of tests cannot be there in every situation. So that is the main problem in defining these patients, because we cannot ensure that all of the, especially in our countries, it is very difficult to get iOS and other techniques that can actually pick up very early disease. Your comments and thoughts, everyone, starting from Dr. Rajiv sir, would like to add on something?
Actually, whatever the longitudinal studies have been done is on the basis of this spirometry.
Yeah.
And yet impulse oscillometry is to be validated.
Yes.
What papers we are seeing now, and the spirometry took at least 20 years for validation, and whatever the technical standard we study now. So I think the impulse oscillometry in the age of artificial intelligence and digitization, maybe we will take a little less time, but definitely COPD is disease of a small airway dysfunction, and people have tried to catch it early by means of where the functional abnormalities has not occurred too much by means of PRM, which you have told, or by CT densitometry. And the other thing, of course, oscillometry technique. And the whatever the study, if you look for the biomarker study, actually they are in the elderly people, where already the COPD has set in. Now, people have even tried to look for the neutrophilic activity, because the neutrophils are, except for the AATD, that is alpha-1 antitrypsin deficiency, when neutrophil elastic activity is being considered a good biomarker. So now a lot of the getomics, what you were talking since the presentation, that is the gene, environment, and time. So getomics has to play a great role as far as this, and we are evolving as far as COPD is concerned. We are get to explore many things which are unexplored, to understand, to change the course, because we don't have any single agent which can alter the course of the disease. Whatever we discuss, the treatment, they are all just to have a secondary prevention or a tertiary. That's my take on this.
Very, very rightly, very rightly said. So just to complete the chart, next slide is just basically because it's an inflammation that is happening. So if you're, next slide, please. So if you're able to identify certain markers, next slide. Yeah, this one. So biomarkers like the mucin hypersecretion markers, as well as the Th2 inflammatory markers, a lot of research, and alarmins as we call them, and a lot of interest has been generated with the TSLPs and anti-TSLP and other things. And in few of these studies that were done very recently that has been published that we have put here, there is people are now started identifying eosinophils and CRPs and fibrinogen levels as biomarkers of early inflammation to see whether these patients, young adults who are smokers with normal preserved lung function, and we are monitoring these patients with these markers and seeing how they are behaving. So a lot of studies are being done and basically somehow identify inflammation in these and aggravated inflammation in them, and of course genetic risk factors we need to take care. And I think we have talked about most of the topics and concepts that are coming up. If anyone wants to add anything and say something, we can do that. And if there are any other questions, we can take it. I think we have come to the end of it. And thank you.
I would like to add a point.
Yes, ma'am. Please, ma'am. Please.
So, so I think all these are possible only in tertiary centers. early COPD should be picked up from the public health center or from early primary level. So there, I think you need a good questionnaire, dyspnea questionnaire like St. George or Bob scale or something like that. And the goal 2023 has talked about even peak flow meter. So use some tool to measure that the dyspnea or the symptom is getting worse. It's better than using nothing. So oscillometry is all in tertiary centers. Not everybody has access to it. I think we should get the point that everywhere spirometry should be mandatory, and the symptom assessment and symptom progression should be the basic questionnaire on which we develop further tests.
Yeah. Yeah. And sometimes these early COPDs do not have symptoms also. That is also something. However, most of the studies have shown that early COPD most of them have, few of them are symptomatic. So in that aspect, as ma'am very rightly said, we need to identify, these individuals, and more, composite scoring as far as the COPD questionnaires are concerned need to be used. Thank you so much. Dr. Bharat and Dr. Arvind, would you like to add on something, or you want to say? Please go ahead. Thank you.
I think the key take-home messages from this is early COPD, there are patients who do not have any symptoms and do not have any spirometric changes, but there could be some changes that can be detected in other impulse oscillometry or MRI scannings. And there are patients who have no spirometric changes, but they have very minimal symptoms, be it the CAT score or by St. George Respiratory Questionnaire. Now, the important point I think from this is which group of patients to treat. I think patients who are having mild symptoms, even with no spirometry changes, and having exposure history either to smoking or to air pollution. In our country, many cities are having very high levels of pollution, or maybe biomass fuel exposure. Those patients who are having symptoms and exposure, I think they should be treated. And I think all these studies have shown us that in this group of patients, bronchodilators are to be used, but steroids, inhaled corticosteroids are to be definitely avoided for this group of patients. Yeah. I think these are the key take-home messages from this.
Thank you. Dr. Arvind, Dr. Vijay Arvind.
I'd like to proceed with Dr. Bharat said. In patients with this pre-COPD group who are much symptomatic, we need to do further investigations like what we spoke about, the impulse oscillometry, CT, and then start on with the bronchodilators.
Yes, thank you. So basically the thing is, we do not have much validation as far as the diagnostic modalities to identify early COPD is concerned. But however, we all have come to the understanding that this is an entity that we cannot ignore, and we need to somehow at least try to manage, pre-COPD. And from those pre-COPD studies, we should be able to have some more, enlightenment as far as the early COPD is concerned, because early COPD is something that is happening way before the patient presents to even the healthcare sometimes. So it's more of a public health perspective, but pre-COPD and some aspects, symptomatic early COPDs, we should be able to identify, and so that we can keep on doing surveillance for these patients. Thank you so much, and all the esteemed, respected panelists and experts here. And thank you. And we had a good conversation. Thanks a lot. I think we've come to the end of it. Thank you so much. Thank you.
Thank you.
I'd like to again thank ICS and knowledge partner Glenmark for organizing this. Since it's a very evolving topic, very difficult to pinpoint these are the factors or take-home messages, but I think all the panelists and the experts have already spoken, and I do not want to repeat them. Thank you once again.
Thank you, everyone. Bye.
Thank you so much. Bye.